Okay, so today we're talking about pediatrics. I am fresh out of the pediatric emergency room for 5 weeks. So we are going to just dive right into this. Really going to just try to focus on high yield stuff here. Okay. So yeah, the APGAR score, appearance, pulse, grimace, activity, respirations. You're performing at 1 in 5 minutes. You can have what, a 0, 2, 4, 6, 8, between a 2 and a 10. Am I reading that correct? 1, 2, 3, 4, 5, 6. Yeah, 2 and a 10 based on extremities, pulse, grimace activity, respirations. Memorize that if you want. Resuscitation, this is probably pretty important. If the heart rate is less than 100, or if the baby is gasping cyanotic, you need positive pressure. The heart rate is less than 60, do chest compressions. That is very important. So less than 60, do chest compressions. Less than 100, you need to do something. All right, you're going to give erythromycin within 1 hour. It's going to prevent neonatal conjunctivitis to either GC or chlamydia. Most likely that's going to be gonorrhea is normally like Rocephin. I think that's more like chlamydia-ish. Vitamin K within 4 hours. We don't know if they're deficient or not yet, so we're just going to give it to them anyway. Hep B is the one that you get like right away. PKU is always checked for phenylketonuria, congenital hypothyroidism. These are the ones that like everybody everywhere gets checked. There's some other things here too, but those are the big ones. Visible jaundice within the first 24 hours is never normal, but you can get it a little bit after that. You can lose a little bit of birth weight, 2 to 3 in 2 to 3 days, but that's going to plateau around 2 to 3 days. If you have something called brush field spots, those are indicative of Down syndrome. And primitive reflexes, I kind of just refuse to memorize these. There's just too much. If I miss one question, I miss one question. So I'm going to skip over all of that. I'm going to skip over my review questions. Let's get into some good stuff. So this is important. So developmental dysplasia of the hip. So it's a thing. It's 9 times more common in girls. They have wider hips even as a baby, maybe. That's just a question I was asking, kind of a way you can remember that. Best of diagnosis around 1 month. So don't get too excited right after birth and try to do all this. So here's the deal. At 1 month is when we assess for developmental dysplasia of the hip. There are two maneuvers that are used in combination with each other. The first is called the Barlow maneuver and involves intentionally dislocating the newborn's hip posteriorly. So we're grabbing it and we're pushing it down. We are dislocating it posteriorly. Okay. So Barlow breaks, in other words. Then we use the Ortolani test, and that is the reduction of that dislocation we just caused, making it a positive test. So O for Ortolani, for out, because when you do or the Ortolani test, the hip is already out. We already did the Barlow. Okay. There's also something called the Galeazzi test, which assesses for differing knee height, and this can point to this DDH as well. So this is a little bit more, we're not dislocating the hip joint, but it's just something you can look at as well with the knees. Pavlik harness is the treatment for developmental dysplasia of the hip. Clubfoot, Talip's econovirus is the most common type of clubfoot. Sure. Syndactyly, webbed fingers, polydactyly, extra digit. You actually tie it off and let it die, and then you cut it off. Pretty crazy, right? Hypertrophy of breast tissue, you can get witch's milk. So you can actually get milk from the neonate's breast. Mastitis, most commonly caused by Staph aureus. So you want to use like your Staph penicillin to your oxacillin, nafcillin, stuff like that. Abdomen, umbilical hernias. This is probably good to know. Omphalocele, where the bowels herniate like into the umbilical cord, but they're still covered by the membrane. If you have a gastroschisis, this is a herniation of the entire abdominal wall like this. So omphalocele is sealed in still, but this gastroschisis, schist is kind of like like a schism or a schism, like a separation, but this is just they're entirely out. Prune belly syndrome, you're straight up born without abdominal wall muscles. I think that's what this is. Hypospadias, this is the one where you get spraying because it's underneath, right? Ventral displaced. Yeah, epispadias is more dorsal. I think I'm getting that right. Imperforate anus is associated with Down syndrome. You can treat an imperforate hymen with estrogen cream. Hydrocele fluid in the tunica vaginalis. You repair the lip first of cleft lip and palate, and then the cleft later. You have microcephaly, which you can get from Down syndrome, or cru de chat, which is this high-pitched cry thing, also secondary to torch infections. Macrocephaly, and then plagiocephaly. And this is, yeah, back to sleep. So you want to encourage tummy time so they don't get this flat head here. Plagio is like plate, which is kind of like flat. Most common chromosome abnormality among infants, Down syndrome. Most frequent form of intellectual disability is also Down syndrome. Good to know. Look for epicanthic folds, brachycephaly, or a short head, dysplasia of the mid-phalanx of the fifth finger, a simian crease, and a poor Moro reflex. We'll talk about heart disorders in a little bit. Know that Hirschsprung disease is like a neurologic thing. So it's a failure of neural crest centers, causes an aganglionic segment. So basically an area of the sigmoid colon here that doesn't have any nerves in it. Big warning sign is a delay in the passage of the first meconium in 48 hours. You want to do a rectal biopsy. And you remove the area that doesn't have any nerves in it. Most common cause of birth defects is simply congenital heart disease. Who knew? Okay, ASD, you want to think A for adult because it may or most likely will present in adulthood. The most common defect at birth, not only is it congenital heart disease, but it's VSD. And you can think of the V as either very young or as like vaginal, like a vaginal birth, like at birth. So always a question that's asked. Then you're definitely going to question, these questions always come up on Rosh, PACRAT, all this type of stuff with like sinus venosus versus ostium primum versus ostium secundum. The most common of the three of the ASD is actually ostium secundum. So I like to talk about sinus venosus first, then go to ostium primum, and then you literally save the best for last, which is ostium secundum, whatever. And that's actually the most common of the three types. But you want to know that ostium primum has to do with Down syndrome. So my brother has Down syndrome, so I just think primum, prime, he's pretty awesome. He likes Optimus Prime. He doesn't, but whatever. So you can keep ostium primum with Down syndrome. Fixed widely split S2 is a good thing just for ASDs in general. So good buzzword, nice question to pick up there. You can see cyanosis and clubbing because you're getting shunting. VSD, you get this Eisenmenger syndrome, some communication between the two circulations, pulmonary artery hypertension and right to left shunting. So kind of similar to tetralogy. So then we have a PDAs, right? So a patent ductus arteriosus. This is normally open in utero, but it should close immediately after birth. The only scenario where we want it to remain open is when you have transposition of the great arteries, which we will talk about in a second. You get that classic machine-like murmur, definitely like a pants question. You're going to get cyanosis, and you can close this with indomethacin. Indomethacin is just an NSAID. The interesting thing here, when I was looking up NSAIDs and why they cause AKIs, it's because NSAIDs inhibit prostaglandins. What do prostaglandins do? Well, they keep open the afferent arteriole of the kidneys. So if we inhibit that, it's going to close, it's going to reduce the perfusion to the kidney. That's why NSAIDs cause AKIs, not because they're cleared through the kidney. Tons of stuff is cleared through the kidney. It's because it closes the afferent arterioles. It has to do with blood. So why are we closing a PDA? Well, if it's open, we're going to get shunting. The baby's born. We don't want any of that anymore, right? We want them to circulate their own oxygenated blood. So we're going to use an NSAID. We're going to use indomethacin, and we're going to close that. So just maybe keep an eye on their kidney functions. If we do have transposition of the great arteries, which is basically like the left and right side of the hearts are like kind of switched, the treatment with this is prostaglandin infusion. What did we just talk about what an NSAID does with prostaglandins? So we want to keep that open. If you look at like the anatomy of transposition, it's crazy that anybody could even live for a minute with that. But we want to keep everything wide open. So you're going to do the opposite of an NSAID. You're going to give a prostaglandin. It's cool. It took me a really long time to understand that. Coarctation, big buzzwords here. You see that rib notching. You see that 3 sign. Is that even on here? Yes, notching of the ribs. You see the 3 sign. Coarctation, you're going to see blood pressure differences, upper and lower. Hypertension in the upper extremities, decrease or absent pulses in the lower extremities. Cyanotic heart murmur, tetralogy of Fallot, you're going to have a VSD, so some connection between the sides. You're going to have some type of pulmonary artery stenosis, some type of right ventricular outflow obstruction. Yes, right. So from the right ventricle, where do you go? The pulmonary artery. So some type of stenosis there. An overriding aorta, where the origin is deviating to the right ventricle. So both ventricles are firing into the aorta, which is why you're going to get deoxygenated blood. That's why it's a cyanotic heart murmur. And then a right ventricular hypertrophy, because if you have a VSD and the left side of the heart is shooting over to the right side of the heart is going to get big and it's going to get strong, and you're going to get a boot-shaped heart. Okay, moving right along. Yeah, the cyanotic heart murmurs, this is like different in like every class. Truncus arteriosus, tricuspid atresia, transposition of the great vessels, total anomalous pulmonary venous return, and tetralogy. Still's murmur and venous hum are normal. Venous hum, the diastolic component is going to be louder. And that's the one that can be confused with a PDA. So you want to get an echo. Still's murmur is the one that's going to be best heard when they are laying down. So venous hum, you want to be very upright. Still's murmur, you want to be lying still, lying down. Okay. Whatever. Neonatal jaundice. Usually correlates with the serum bilirubin over 5 milligrams. Okay. Kernicterus is a big buzzword for cerebral palsy. I think that's important. Know that glucuronoltransferase and glucuronic acid are things that are important with conjugation, unconjugated to conjugated bilirubin. Remember that visible jaundice is never normal within the first 24 hours. You can get it either from breastfeeding or from lack of breastfeeding. So that's pretty interesting. I'm going to nurse at least 10 times daily for the first 2 weeks. Yeah. Okay. So this I like to talk about because this took me a really long time to understand. So I'm just going to read all of this. It took me years to understand RH factor. So I'm just going to read this. So I spent a lot of time on this blurb. Okay. So I don't even know how to say it. Rhesus. We just call it RH. Rhesus. It's simply a protein found on the surface of red blood cells. Most people are RH positive. All right. 70 to 90% based on what I found. So most of us have the Rh protein on our blood cells. The other minority don't have this Rh protein. So for example, if my A positive blood, which that's actually my blood type, so positive means I have the Rh factor, that was given to somebody who was A negative, they would form antibodies to my Rh positive blood, and this would cause hemolysis, right? So that's not good. It would form antibodies. Okay. The body just recognizes the blood with this foreign Rh protein as an antigen, creates antibodies, and attacks. Okay. There's a problem, however, when an Rh negative mother is pregnant with an Rh positive baby. There's some mixing of fetal blood and mom blood during pregnancy. So some of that Rh positive blood from baby will enter into the mom's circulation, and she will develop antibodies to the protein antigen. Essentially, she's creating antibodies against the blood of her baby. Now, this isn't a huge deal during the first pregnancy because it takes a while for the antibody levels to get to a dangerous amount. So usually the first time this happens, the baby is fine. And what's critical here is we didn't just change the mother's blood type or anything. She's still Rh negative with no Rh proteins on her red blood cells. If she was, she'd die instantly because she now has Rh antibodies. So that's the key here. She now has antibodies that she didn't have before. So she's primed to attack if anything with Rh gets into her blood because a little bit already did. It's like she got a vaccine essentially from her Rh positive baby. You get these IgM immunoglobulins, which are created first, and then the IgG come later and actually do the attacking, I believe. Okay. However, if she becomes pregnant again, and this baby is also Rh positive, there is this giant invader now in her, ripe with these Rh antigen proteins, right? The baby inside of the mother. And mom has fully primed antibodies. She is fully vaccinated, in other words, against this Rh positive baby. So even if an ounce of her blood mixes with the baby's, mom's blood, those antibodies are going to attack the baby's blood, right? And they'll cause hemolysis of the baby's blood. So what do we do about this? So at 28 weeks or any time before that, if mom has any type of trauma or vaginal bleeding, we'll do this before. But at 28 weeks, if mom is Rh negative, regardless of what baby is, she receives RhoGAM. So 28 weeks is basically when all this goes down, blood can start mixing more. I think it covers her up to like full term as well. So what is RhoGAM? So the idea here is to not ever let the above situation occur. We catch this before it happens and prevent primed and ready antibody-ridden mothers from walking around. So we want to catch this the first time. Okay. So instead of mom's immune system recognizing and remembering the Rh positive blood, RhoGAM, which is just Rh immunoglobulin, it gets there first. So we administer the RhoGAM and it kind of gets there first and it neutralizes the Rh positive blood from baby that got into mom before her immune system gets a chance to locate it, react to it, and create memory cells, plasma cells, and antibodies. The RhoGAM isn't enough to cross back over into the fetus and start attacking that blood. So it's all about the very precise dosing here. There's a good video here called How Rh Factor Affects a Pregnancy. So why do patients get abortions well before that 28-week mark when RhoGAM is normally administered, need RhoGAM? I'm honestly not sure. I mean, I get that if the aborted fetus is Rh positive and the mother is Rh negative, there's a problem. I guess because an abortion is traumatic, there's blood loss with mom and baby and it mixes that way. That makes sense. And this question I asked, I think it doesn't really matter as long as you give RhoGAM to prevent that. I'm not sure. That's getting too far into the weeds. Hydrops fetalis has to do with alpha thalassemia major, which is hemoglobin BART for gamma globulins. Cool. There's something called a KEL, like antibody. It's the most common of the minor hemolytic diseases. There you go. Pyloric stenosis can cause elevated bilirubin, Gilbert's disease, et cetera, and henceforth and so forth. Anything important here? Yes. So the contraindications for breastfeeding, there's 6. So one is galactosemia. This is a condition where the baby is unable to break down galactose, which is actually a big deal and causes a ton of issues. I think that's the main type of sugar that's in breast milk. Mothers receiving radioisotopes or chemotherapy, or chemotherapy. Active tuberculosis, mothers who are using drugs, mothers with HIV. And then, you think like HIV, you don't want to share needles or get like stuck with blood from somebody. So yeah, you certainly don't want to mix breast milk. And then mastitis with an abscess. That's actually a pretty good one. So try to remember those. Yeah, HIV. If you have Hep B or Hep C, good to go. If you have a fever, good to go. If you smoke, you're good to go. If your baby has jaundice, yeah, breast milk can help that. And if you have simple mastitis without an abscess, make sure you give vitamin D if you're exclusively breastfeeding. You want to exclusively breastfeed for the first 6 months. A lot of antibodies, a lot of good stuff in that milk. You want to do 8 to 12, so basically 10 feedings for every 24 hours. Crying is a late indicator of hunger. Breastfed infants do not need iron, they just need vitamin D. 400 IU/PO daily. You want 6 day wet diapers in 24 hours. After the 6th day of life is when you could start really counting that. So 6 to 8 wet diapers in 24 hours after the 6th day of life. Formula options. You don't want to introduce whole cow's milk until 12 months. That's important. In terms of body weight, usually it doubles. Yeah, it doubles at 4 months, triples at 12 months. Those are good things to know. Whatever. Most common secondary causes of obesity are hypothyroidism or Cushing's. I think that's actually really important. I usually color this red. I think that's really important. Prader-Willi syndrome. I think that's like a hoarding thing where you eat a lot of food. Blount's disease. No. Any of this important? True apnea is greater than 20 seconds. Sunken fontanelle indicates dehydration. Know that the posterior fontanelle closes at 4 months. Anterior fontanelle closes at 18 months, I believe. For otoscopy, pull pin it out and down. That would have been helpful. I was not doing that. Umbilical granuloma is the most common cause of umbilical. I can't say words. After the cord stump falls off, umbilical drainage. Yeah, it's definitely umbilical. It's like the umbilical cord. Don't forget pyloric stenosis, non-bilious projectile vomiting. Yeah, and I was like looking for pyloric stenosis in like a 12-year-old. It happens within like the first 2 weeks of birth. Very, very young for pyloric. You're not going to see that in a 1-year-old even. That's something I didn't understand for quite a while too. A thyroglossal ductal cyst is the most common congenital cyst of the neck. I think that's really important because I put it in purple. Nose picking is the number one cause of epistaxis. So, foreign trauma, self-inflicted. Yeah, whatever. That developmental milestones chart, vaccines. Again, is it worth it to memorize all of that, which is something you can Google clearly to get one question right? Probably not. Probably not. I did have them all memorized at one point. Not now. All right. So, what are the big things for this? Keep it together. Here we go. Here we go. All right. 6 months. You want to know that teeth appear. I think that's a big one. Again, 4 months, birth weight doubling. 12 months for standing. I'm sorry, for walking. Your weight is going to have tripled. Your height is going to have increased by 50%. You can introduce whole cow's milk. 18 months is when that anterior fontanelle closes. 4 months should be where our posterior closes. Right? Oh, it's 2 months. Did I say 4? 2 months. 2 months is where our posterior fontanelle closes. I think I said 4. That's 2. Rice cereal. Sorry about that. 2 months. MCHAT happens at 18 and 24. So that is for autism. I think that's important. Blood pressure gets starting measured at 3 years. You stop measuring head circumference at 2 years. I think those are the big ones, honestly. Okay, about halfway through. Most common pediatric complaint is a fever. It's at highest at 6 p.m. Rectal temperature is the highest. Fever directly inhibits Kawasaki and polio. I just did a presentation today on why treating fever aggressively for no reason isn't the greatest idea. 100.4 is like our good baseline for pediatrics. This stuff's pretty important. So you want to know group B strep, which is Galactiae, Listeria, and E. coli are the big players for like young neonatal infections. All right. You're gonna, UTIs, occult bacteremia, and then obviously like meningitis. Treatment for this, you want to be pretty broad. So you want to use ampicillin. So that is just IV amoxicillin. And that's going to cover, it's a great gram-positive killer that kills your group B strep. It kills your listeria. And then gentamicin, which you also use for listeria as well, but that's going to be a gram-negative killer. So that's going to help for E. coli or anything else gram-negative. Or ceftriaxone, which is a third-gen cef, which again is a great gram-negative killer as well. So definitely you want dual coverage. Make sure you're covering a lot of things. If you have like a bloody LP or you think they could have like herpes or something viral, then you would add in acyclovir. You can also consider adding in Vanco, which would be a good thing for like a strep pneumo meningitis. Obviously, that's going to cover MRSA as well. Again, we have ampicillin and ceftriaxone, and then we start adding in vancomycin as they get a little bit older. So it's usually like, I mean, those three are going to be a pretty big thing. A lot of different options. This is always a big thing that comes up. So less than 24 months at risk for UTIs and uncircumcised boys in general. So once girls reach the age of 2, they're lower risk. And then if you're a circumcised boy, you graduate out of this at 6 months. So girls less than 2 and uncircumcised boys less than 12 months are the high risk here. But if you're a circumcised boy, you're like out of UTI land at 6 months. Then the uncircumcised at 12, and then girls at 24. Sure. Okay. What do you need to know about measles? No Koplik spots and grains of salt. No, you get conjunctivitis, cough, and coryza. This is a paramyxovirus. You can use vitamin A for that. Always a good thing to know for measles. Mumps has to do with parotitis, big buzzword there. Orchitis, pancreatitis, and then deafness because it's right here. It can lead to like mastoiditis. All right. You just isolate for that. Treatment for most of this is supportive. Rubella is going to be a torch infection. You get these Forchheimers or petechial lesions. You're going to get cervical lymphadenopathy. That's a pretty big one, especially in the posterior. So you could think this is like an Epstein-Barr. You're going to get a sore throat. You're going to get conjunctivitis. I think you get like preauricular lymphadenopathy. Parvo, just like 16 names: parvovirus B19, erythema infectiosum, fit disease, and like the slap cheek. So slap cheek is the big one there, and a lacy rash. Another really good question that bleeds over into like literally bleeds into hematology is that you can get into a aplastic anemia crisis with sickle cell patients. Really, really big thing. Arthritis as well. So you get this normocytic anemia, aplastic anemia with parvo. So look for a low retic count. Also want to stay out of the sun. So tons of interesting stuff about parvo. People love asking about that. Roseola infantum. This is the fever that rashes. So you have a high fever for 4 to 5 days. That turns into a rash. By the way, if you have a fever greater than 5 days, that's really not going away, then you're getting into Kawasaki's territory, which I think is probably on here somewhere. Probably not. That might be like a just in room. Yes, so this is actually a herpes virus, 6 or 7. So roseola is in the herpes family. It's also called sixth disease, which I think has to do with this. They don't really call it that. And then we have Coxsackies, which of course is hand, foot, mouth disease. Really no buzzwords here. I mean, you'll see this. You'll I saw this a couple times. The vignettes for that are pretty easy. But just don't get like roseola confused with pityriasis rosea with like rosacea. Um, there's even like another one. So just try to keep those clear. Asthma, I mean, I'm not going to go through asthma. That's more of a poem thing. I did a whole video on poem. Parents are the most common abusers of children. Sexual abuse is the highest category. Bruises are the external hallmark of injury, seen in 75% of injuries. Another good question that I feel like is asked often is like when there's a mixture of new and old bruising. Make sure you rule out like HSP, which is just like a reactive, like viral thing, coining, which you can Google, cupping, you can Google Mongolian spots is just like a benign, like dermatologic thing. Coining is popular in like I don't know much about it. I don't want to like speak out of turn. It's big in like certain Asian cultures. Apparently it works pretty well. You basically take like a quarter and just rub it up and down the skin, and it like makes them feel better. That would be an interesting paper to read up on. Bites, burns. I memorized all this and then realized we didn't have to know any of it. Bucket handle fracture. I've never heard of that. Osteogenesis imperfecta comes up somewhere else. Forget where. But a blue sclera, that's a good buzzword. Blue sclera, osteogenesis imperfecta. This is a non-abusive cause of fractures. If like a young kid comes in with like a femur fracture, make sure you rule this out before you call like CPS or something. Most common cause of death from a child abuse is head injury. Simple linear parietal fracture is the most common. So there you go. Look at the size of the parietal bone there. Shaken baby syndrome. You want to look for yeah, retinal vitreous hemorrhage. That's like pathognomonic. That's a big thing. Children under 2. Rapid fire. Okay. Sure. Cap it. Suck it. Didn't. This is the one that crosses the suture line because it sucks. It's right in the term. All right. So caput, suck, sucks. That's the one that crosses. Cephalohematoma is just a traumatic hemorrhage. Herb Duchenne palsy. Yeah, that's with like the arm. That's like damage to the brachial plexus from like a traumatic birth. Yeah, like shoulder dystocia and you nerve damage, whatever. Peds dosing, yeah, Titus media, no, it's 90 per day, 45 mg per kilogram BID. It's important. IV fluids, usually like 20 to 30 mLs per kilogram is the rate that you want, or at least like the weight. Pharyngitis, I mean, I'm not going to go over center criteria and stuff. Again, we go over this a lot in POEM. Know the common offenders for otitis media, strep, pneumo, H flu, MCAT. Those are your typical community acquired sources of pneumonia as well. Yep, there's your amoxicillin. 90 strep throat. The dosing is a little less. I think it's like 15-ish. Croup, you want to do racemic epi if things are getting crazy. They're always going to get dexamethasone as well. Remember that yeah, albuterol is not going to do anything in this case, and that this is totally viral, right? Bordetella pertussis is bacterial. That's whooping cough. And croup, which is going to be your seal bark cough, is viral. All right, and you're going to see that steeple sign, which I actually did see in the ER with a kid with croup. Pretty crazy. Oh no, oh no. Tylenol 10 to 15 mg per kg, and what's ibuprofen? 10. Yeah, no, thank you. UTIs for kids, cefixime, I think that's crazy expensive. I think they just give Keplex to a lot of people, which we never really learned. But you can use Augmentin, you can use Bactrim, this macrobid derivative, macrodantin. Sure. Vesico-ureteral reflux is the most common urologic abnormality in children, and you want to use a voiding cystourethography or a VCUG to look for reflux. All right. I'm going shy. Can you tell I'm like kind of over it? I'm hours away from the end of this first semester. Blah, blah, blah. Constipation is the most common cause of abdominal pain. Appendicitis exists. Meckel's diverticulitis is back and presents with painless rectal bleeding, bowel obstruction, and mimics appendicitis. Sure. This is important. It's a intussusception. Make sure you get an ultrasound. Sausage-shaped abdominal mass, current jelly stool. If you have current jelly sputum, it's Klebsiella. Gram positive or gram negative? Gram negative. What's like the complications and stuff with that? It's like liver stuff, right? Liver disease, like diabetics, maybe. There's like some liver stuff with that. That's enough. Intussusception. This is like episodic vomiting or is it diarrhea? I think it's just like episodic like pain. Yeah, episodic pain and cramping as that peristalsis is like trying to work its way through that intus. But yeah, it's the current jelly stool. I'm sure you can get vomiting too. Cyclic vomiting. 20 cc per kilogram bolus. Okay, that kind of meets that 20 to 30 per kilogram. You can use 5 mLs of Pedialyte. You always want to do hydration, orally whenever possible. Rheumatic fever, ASO titers. Yeah, you have like your space criteria and stuff. Erythema. Marginatum would be for rheumatic fever. I think that's that like serpinguous, like snake-like one. Penicillin is always going to be your go-to. Amoxicillin, some type of penicillin derivative for any type of group A strep, which is strep pyogenes. Kawasaki disease, also thought we had a case of this, but didn't end up being the case. You can get this, strawberry tongue. You're going to get, it's 10 days of high fever. I thought it was like after 5, you would start to think this. Oh, yeah, it's right here. So high fever, not responsive to antipyretics for at least 5 days. It has these 3 different phases. Treatment here is high dose aspirin or IVIG. You're going to get conjunctivitis. I think that's a really good thing for a vignette. You're going to get thrombocytosis, which is why you're giving aspirin. So they're getting too many platelets, and you are going to give them an antiplatelet. This is actually the most common vasculitis in children. And even though it's of the medium-sized arteries, it's going to, the coronary arteries, which are pretty small, are technically medium-sized. I guess small arteries would be like arterioles. Maybe that's what they're getting to here. I don't know. But yeah, strawberry tongue. Not to be confused with, I think you can get a strawberry tongue with group A strep too, and like a sandpaper rash. And you get like there's like a finger finding here too. But I think the vignette would be pretty clear there. Please be done. Please be done. What else is left? Emergency stuff. No, that's it. There wasn't really anything big. That's it. I know that was lightning fast, but hopefully that'll help pick up some points on this EOR, and I will see you in the next one.